Thank you, Dr. Bramble and Dr. Racy for having me, and thank you to everybody in the audience that is willing to listen to me talk. As a rheumatologist, I see a lot of patients with pulmonary hypertension, but I see a lot of patients with interstitial lung disease. And so consequently, I see a lot of patients with both, and that can be quite challenging. And we have wanted to try to treat these patients, and it has been challenging over the years. And I really think the treatment paradigm is starting to change as we understand these different groups better, some of which is through the work of ph-ild that Dr. Farha and Dr. Hemnes is involved in. So I'm going to talk a little bit about this. And, you know, in the ILD world, we think about how do you get interstitial lung disease? Usually there's a disordered fibrotic pathway. In the case of rheumatologic disorders, there's a disordered immunologic pathway. But there's this thing called the vascular hypothesis. And we see that in scleroderma ILD, we see that in idiopathic pulmonary fibrosis. If we do a BAL and measure thrombin in these patients, it's elevated. If we put thrombin on a fibroblast, it turns into a myofibroblast. So there's an inherent connection between some of the pathobiology of pulmonary hypertension and the pathobiology of interstitial lung disease, which kind of makes this a really interesting area. Here are my disclosures, and we're gonna, today talk about the burden of pulmonary hypertension, interstitial lung disease. This is not a good thing to have. We'll talk about some risk factors so that you can better identify these patients. Until recently, there was nothing we could do about these patients, so we didn't even really want to look for pulmonary hypertension because there was, maybe we could transplant them, but there was nothing to do. But now we have an opportunity to maybe help these patients. We'll talk a little bit about these mechanisms. We'll examine criteria and methodologies to accurately diagnose and evaluate these patients. It kind of is the same as pulmonary arterial hypertension, spoiler alert. And then we'll talk about some of the different therapies for pulmonary arterial hypertension that have been tried in interstitial lung disease associated pulmonary hypertension. So we know this is common. It's common in chronic lung disease, whether this is our COPD end of things or interstitial lung disease end of things. And it's very variable. And part of this depends on how you're looking for pulmonary hypertension, whether you're screening by echo, whether you're doing formal right heart catheterizations, what your population is and your referral bias. But in COPD, it's somewhere between 1 and 50%. And we're not going to talk about COPD today. But in idiopathic pulmonary fibrosis, it's somewhere between 8 and 86%. Some of that difference relates to, the higher prevalence comes from studies of transplant centers where they're seeing kind of the more advanced interstitial lung disease. And then, of course, we can see this in sarcoidosis, 6% to 74%, remembering that sarcoidosis actually fits in group 5 and is not a group 3 disease, although they can have, a lot of disordered pulmonary parenchyma. So we've been taught that pulmonary hypertension in interstitial lung disease is not that bad, that it's modest. That's kind of what I learned growing up in the PH world, and that the mean pulmonary arterial pressure is modest. If it's much above 35, you have something else going on. Maybe this is pulmonary arterial hypertension from the scleroderma and they just happen to have a smidge of ILD, that there's something else going on. But this is not the right way to think, because pulmonary hypertension, as you all know, is a disease of vascular resistance. It's not a disease of pressure. So even with a very kind of quote unquote modest elevation in mean pulmonary artery pressure, this significantly impacts survival And here you can see patients with this very modest increase has substantially worse survival, where at 1 year, that's the dotted line, you go from somewhere around, 95% down to 80% in survival, and it just exponentially goes down. And this is not just an IPF phenomenon. You can see this in chronic hypersensitivity pneumonitis. You can see this in all of our interstitial lung diseases. And in fact, data from the ph-ild database shows that of all our different groups, group 3 pulmonary hypertension patients really do worse. And here you can see data from, the blue is idiopathic pulmonary arterial hypertension. This is pulmonary hypertension due to idiopathic interstitial pneumonias. It's bad. And we all know that pulmonary arterial hypertension is bad, so this is badder. We need to do something about it. And what's interesting also is that if you have pulmonary hypertension in the setting of IPF, you're more likely to have an acute exacerbation. And we all know that, that has an 80% 3-month mortality. This is not a good thing to have. And just like pulmonary arterial hypertension, this is a progressive disease that progresses, and then you develop right heart failure, and then you die. And so this is patients that are being evaluated for transplant that have this, very modest increase in pulmonary pressure, but as they're being followed, they get swanned up in the whole bit. It is worse, so this is progressive. So just like you need to follow your patients with pulmonary arterial hypertension for progression of their disease, you have to follow your patients with group 3 ph-ild for progression of their disease. And so we have these pathogenic mechanisms that are involved in both pulmonary fibrosis and pulmonary hypertension. And so it's logical that over the years, investigators have tried to expand the use of our therapies. Not only have they used the ERAs to look for, treatment for ph-ild, but they've looked at it for treatment for ILD. And that's because, you have, similar things. You have the apoptosis, and you have proliferation, and you have activation of nuclear factors, and PGGF and TGF-beta, and then you have this combination of vasoconstriction and proliferation and elevations in endothelium and more proliferation. And all these things that this oxidative stress mechanism where you have, involvement in soluble guanylate cyclase and cyclate GMP. And so it makes sense that we've been tempted to stretch the envelope. Here's data from patients with scleroderma. This is a lung biopsy of a healthy person with a healthy lung with scleroderma interstitial lung disease. And you can see how intense it stains for endothelium-1. We know hypoxia increases endothelium-1. And there's elevated levels of endothelium-1 and BAL fluid from these patients. And you can see if you give a Petri dish bosentan, that there seems to be less, smooth muscle action and less contraction of the gel. One of the challenges, though, is when you look at the pathologic changes in pulmonary hypertension, interstitial lung disease, is not only are we seeing that pulmonary arteriopathy, but we are also seeing venule involvement. And that's one of the changes. So these people sort of act like PVOD, if you will. One of the interesting things is we don't typically see the plexogenic lesions in these patients, but more just really intense medial and intimal hyperplasia, as well as some adventitial stuff. I'm double fisting it today. So how do we look for these patients? Well, one clue, if you're following your patient for interstitial lung disease, is that they have shortness of breath out of proportion to their interstitial lung disease. Maybe their PFTs just aren't that bad, and you're like, why are they belly aching like they are? That might be a clue that something else is going on. Obviously, if they have findings of right heart failure already, like a P2 or edema or JVD, those things on physical exam are certainly clues. We always worry about someone who's presenting with syncope or near syncope. Now, it may be that they're refusing to wear their oxygen, but if your patient's complaining of near syncope or syncope and they have interstitial lung disease, you better, hightail it to the echo lab. These patients tend to have a pretty low diffusion capacity. Particularly scleroderma patients, we use this ratio, the FVC to diffusion ratio, so that if the diffusion is down out of proportion to the FVC, that will raise that ratio. Think, could they have pulmonary vascular disease? They're more likely to have nocturnal hypoxemia. If you were to do a CPET or invasive CPET, and we know Dr. Tonelli is like the wizard at these, he would tell you that there's increased dead space ventilation and a cardiovascular limitation to exercise. These patients tend to have really cruddy 6-minute walk distance. And interstitial lung disease providers tend not to be 6-minute walk orderers, but the 6-minute walk is something that, the PH people have had a love-hate relationship, but currently we love it. But a low walk distance is not only a prognostic marker, but it could be a clue, as well as significant oxygen desaturation. And another clue is decreased heart rate recovery. Now, most people with interstitial lung disease will get a CT scan, so that can be a clue. When the pulmonary artery, when you compare it to the aorta, when the pulmonary artery seems bigger than the aorta, that's highly suspicious, or the right chambers of the heart seem to be dilated. NT-proBNP is a good, easy screen, of course. It might be in Dr. Bhattacharya's and Dr. Jacobs' area, because people with ILD also have diastolic dysfunction to make things even more fun. And then, of course, the echo, right ventricular systolic pressure. We've all been taught about the challenges of that in patients with advanced lung disease. But there's a lot of other things that our friendly cardiologists tell us about morphology and function. And so if we look at the right atrium and the right ventricle, that can provide us clues. And then, of course, there's certain interstitial lung diseases where you're even more wary for the presence of pulmonary hypertension, such as connective tissue disease, i.e. scleroderma. But you can see this in other, Sjogren's and rheumatoid arthritis and those too. Sarcoidosis, pulmonary Langerhans cell histiocytosis. Now, typically, the worse pulmonary function you have, the more likely you might have pulmonary hypertension. But this is not, you can't say, well, I can correlate forced vital capacity with mean pulmonary artery pressure. You can see it is a total scatter plot. And there are patients with mild interstitial lung disease with significant pulmonary hypertension. There's patients with severe interstitial lung disease with no pulmonary hypertension. So, don't wait until your patient has one alveolus to check for pulmonary hypertension. Think about it immediately upon the diagnosis of ILD. Here's data from Virginia Steen out of Georgetown in scleroderma, where she just looked at the diffusion capacity, and the patients, with a diffusion capacity of 40% with scleroderma were more likely to have pulmonary hypertension. And this is data from Dr. Seibold, who's another big scleroderma person, used to be at University of Michigan. I think he's in South Carolina now, where he looked at this FVC to diffusion ratio. So this ratio, people have used different cutoffs. I've seen between 1.4 and 1.8. I split the difference, 1.6. But, very worst prognostic indicator, and this is a clue. And here is data from a study that looked at patients with IPF with and without pulmonary hypertension, with a mean pulmonary artery pressure of 25. And so we know that that's changed over the years. But these patients really had a significantly low 6-minute walk test. They were more likely to significantly desaturate, and they had a significant increase in mortality. And here's a little bit more data from the same paper on heart rate recovery, which not only predicts survival, so we know that heart rate recovery predicts survival in pulmonary arterial hypertension as well. That was done by Dr. Minai, who used to work at the Cleveland Clinic. But we also know that it predicts the presence of pulmonary hypertension and idiopathic pulmonary fibrosis. So 6-minute walk test, can be a useful instrument in more than pulmonary arterial hypertension. Here's an example of the pulmonary artery size. I had to, right before this morning, I was looking at my talk, and this red line was over here. But the red line should be across the main pulmonary artery, and you can see that this is bigger than the accompanying aorta. And when you see that the pulmonary artery to aorta ratio is greater than 1, this line, worse prognosis. But we can't predict based on size or based on degree of fibrosis what the mean pulmonary artery pressure would be. It's kind of yes, no. So you could have, again, not much fibrosis and pulmonary hypertension, or you could have lots of fibrosis and no pulmonary hypertension or wicked pulmonary hypertension. It's just a yes, no. These are clues. You still have to do your pulmonary hypertension workup. Here is, there was a transplant study that included COPD and IPF from, University of Pennsylvania, I believe, that kind of showed the same story. This is just in patients with interstitial lung disease, which show that the echo over and under represents pulmonary hypertension, and it's accurate. It's like less than a coin toss. So you can't just look at RVSP. Take your time. Your cardiologist is going to tell you all sorts of great stuff about the echo. And plug that in to this kind of pretest probability of could your patient have pulmonary hypertension. Look at those other variables. If those variables are there, go on and evaluate your patient. Here is, now you can start to use a multidimensional approach. Here's a paper that looked at, well, what if we combine pulmonary function tests and 6-minute walk? You can see that if you combine those, that there is improved, sensitivity and specificity over those measures alone. So, kind of to summarize our useful assessments: history, disproportionate shortness of breath, loud P2, signs of right heart failure, PFTs, low diffusion or elevated ratio, exercise capacity, low 6-minute walk, increased desaturation, low heart rate recovery, CT, increased pulmonary artery to aorta ratio, RV bigger than the LV, elevated BNP, echo, RVSP, but all these other things about right-sided morphology and function. And then you need a right heart catheterization. That remains the gold standard. Doesn't matter who group you are, it's the gold standard. We are super fortunate here at the Cleveland Clinic because we have Dr. Tonelli and Dr. Cucci, and now we have Dr. Suba, who are taking into considerations respiratory variation. They're taking into consideration position, obesity. They're doing all these things to account for intrathoracic pressure to give us really good numbers, because these right heart catheterizations are not easy to do. But it needs to be done. And so we've confirmed pulmonary hypertension, and then we kind of have to say, all right, how are we going to think about this patient? And in my mind, is this a big 1, little 3, or is it a big 3, little 1? And I'm so fortunate that we have PV-domics that's going to help us answer this question on a more granular level. But right now, we're kind of stuck with this. Is it, are your PFTs super, super bad? Is your CT super, super bad? And are your hemodynamics not horrible? Then it's probably group 3. If the opposite is true, PFTs are not horrible, CTs not horrible, hemodynamics are horrible, then maybe it's group 1. And so this is the art of treating a patient with pulmonary hypertension. And, there's a lot of people sitting in this room that do this every day and are super smart. And sometimes they're flying by the seat of their pants, myself included. This is hard. And because of that, I would encourage you to collaborate with your favorite pulmonary hypertension person, because these decisions are hard. Because what happens, we can worsen oxygenation because we can worsen VQ matching. These patients can act PVOD-ish, so they can go into pulmonary edema. Or they have similar risk factors for, the HFpEF stuff, and so we can participate, or we can precipitate pulmonary edema that way. So it can be really challenging. But we're still doing it. This is data from the Compara registry that looks at, what are they doing over there in Europe, those crazy Europeans. They're kind of doing some of everything. It looks like they tend to lean on PDE5s. There's a few patients that may have been on an ERA or may have been on a prostacyclin or some combination therapy, and sometimes there's a decision not to treat these patients. So, of course, all the general measures we should do, treat the underlying disease, maybe they need mycophenolate for their scleroderma, get them, immunizations, diuretics, all that stuff, oxygen. You don't really want to biopsy these patients if you can avoid. And you really should be thinking, can this patient get a lung transplant? Because that's really the definitive treatment. So here's kind of a summary of our ERAs. All of them, they've tried. The BuIld studies. There was BuIld 1 and 2 in IPF and scleroderma. There was BFIT, which, they had right heart catheterization confirmed ph-ild. That was negative. The MUSIC trial, which was macitentan, didn't show improvements in functional status or slowing disease progression. Artemis, which was ambrisentan in IPF, was terminated early. Both of these. So there's actually a caution against the use of these antagonists for ph-ild based on these studies. We just do not have good data for ERA. Well, what about sildenafil? The STEP IPF trial was, they had advanced idiopathic pulmonary fibrosis, so this is just one type of ILD. And it was enriched for pulmonary hypertension based on a low diffusion. And the study did not show an improvement in 6-minute walk distance. The primary endpoint was greater than 20% of 6-minute walk distance. So of course, you have all these ceiling and floor effects with 6-minute walk based on a variety of non-cardiopulmonary properties. There seemed to be a trend, though, towards a mortality benefit, and it seemed to improve some quality of life measures. Oxygen saturation was not a problem. Maybe diffusion was better. And investigators felt that sildenafil was probably not harmful, maybe could be beneficial, but kind of wishy-washy on, any, real conclusive evidence. And then they looked at sildenafil adding on to nintedanib, as all, probably all of you know nintedanib is FDA approved for IPF. And it's interesting, if you look at basic science studies in nintedanib, there is some biological rationale where nintedanib could act on the vascular pathway. We don't really know in real life, but in a mouse, of course, mice get better if you treat them with ketchup, but in mice, it's interesting, and I think it kind of ties together that whole vascular and fibrotic. But anyway, they added sildenafil to IPF. And, they did not see differences in different questionnaires for dyspnea. And then they looked at forced vital capacity. Not real differences, but the combination arm is on top, which is a little bit interesting, I think. And then they looked at sildenafil versus pirfenidone, and it didn't matter what the outcome was. Clinical worsening, time to mortality, time to hospitalization, all that stuff, they're equal curves. So absolutely no evidence for sildenafil combined with pirfenidone. What about riociguat? Riociguat is not advised in Group 3 ph-ild, and we were so excited. This was going to be the drug. And then the study was terminated early due to increased risks of serious adverse events and death in the treatment group. And so it is not advised to go there. And then we have the latest kid on the block. Of course, maybe we've been using this off-label like we tend to do as physicians, ignoring what all the evidence says. So they said, well, let's look at inhaled treprostinil. It seems like a good idea. You're inhaling it, so therefore, at least theoretically, you could preserve VQ matching. So this was the INCREASE study that randomized people to inhaled treprostinil versus placebo that had interstitial lung disease. And they had all sorts of interstitial lung disease. Almost 25% had an underlying connective tissue disease. And what this study showed was, that there was a significant improvement in 6-minute walk distance in patients that were on inhaled treprostinil. And this is a treatment difference that is in line with the treatment difference that we saw in pulmonary arterial hypertension. So this was really exciting. And then it also showed that there was decreased clinical worsening and improvement in NT-proBNP. And so all these endpoints were aligning in the right direction, and there was no safety signal that was any different than the safety signal that was seen in the pulmonary arterial hypertension studies, kind of the usual cough and headache and, things like that. But even more interesting is they got forced vital capacity as a safety endpoint. Because they thought, here's these people have ILD, we're gonna have them inhale something. God forbid we make their ILD worse. So they followed forced vital capacity. And I think everybody was surprised that there seemed to be a difference in the slope of forced vital capacity in patients randomized to inhaled treprostinil versus placebo. And what's even more interesting is they got forced vital capacity as a safety endpoint in the PAH trial. Those people did not have ILD, and there was no real difference. So these people have ILD, and there is a difference. So the question was raised is, do the prostanoids, does inhaled treprostinil, is there any benefit for the ILD? We don't know that yet. This is hypothesis generating. There are studies going on, but it's certainly interesting. So with that, I can summarize. The pathobiology of ph-ild involves a complex interplay between vasculocentric, parenchymal, and comorbid phenotypes. This diagnosis requires a thorough physical exam, exercise assessment, CT, echoes, biomarkers, i.e. NT-proBNP, PFTs, right heart catheterization. And to me, this is like the same thing that you do in pulmonary arterial hypertension, so this isn't really a newsflash. Although, there are extra clues with the CT scan. Differentiating between group 1 and group 3 is, I struggle with this every day, and this is what I do for a living. And I hope Dr. Hemnes and Dr. Farha are going to answer this question soon. I'm depending on you, Dr. Farha, sitting there. And inhaled treprostinil can be used in ph-ild patients with right heart catheterization, proven pH to improve exercise capacity. And I'd like to comment one more thing about that study. The mean pulmonary artery pressure in that study was not that bad. It was quote unquote modest. It was in the 30-35% range. But if you looked at the PVR was 6. So a modest mean pulmonary artery pressure does not mean you don't have real pulmonary hypertension. I think we would all agree a PVR of 6 is real pulmonary hypertension. Riocyclot is contraindicated in ph-ild. It's a great drug for PAH in group 4, not so good in group 3. And endothelin receptor antagonists don't have a favorable recommendation. There's some evidence supporting sildenafil, but it's limited evidence, and I think we have to be cautious. And these patients should be monitored closely for improvement, side effects, and potential worsening. When I treat a patient, I tell them they are an N of 1 experiment. I might help them, and that's the goal. They might not get better, and I might make them worse, and I make them very clear about that so that they know what that looks like. And we do stop drugs on these patients because we do make them worse sometimes, despite our best efforts. And fortunately, I have Mindy and Doug. I used to have Nancy. She quit us. And Christine, that are so good at helping us monitor these side effects, which is one of the benefits of having your patient come to a pulmonary hypertension program, because you're so well supported by staff that can help, bird dog these side effects. And, I put Nancy's cell phone on my Facebook page, so they call her at home. And that's all I have.
Thank you so much, Dr. Highland, for that thorough overview of Group 3 PH.